Thank you very much, everybody, and thank you for inviting me to be able to speak. Not being on this side before of the podium, it's a little bit different, I have to say, from sitting on your side, but I'm sure it'll be fine. So before I start, I'd like a show of hands for people who have had experience in an outbreak, and I'm not talking CPE, just generally outbreak experience. Fantastic, all there. Keep your hands up and leave your hand up if you've had experience in a CPE outbreak. Excellent. You're the unlucky ones like me. I find that CPE, when we first got our very first outbreak, and I thought, all right, yeah, it's a CPE outbreak. Yep, we can do this. We're used to outbreaks. Oh my goodness, it's a whole different ball game. I'll stand here and say I don't have the answers to everything, but what I can do is absolutely share my challenges. And all of you in the audience who've had CPE experience, some of the challenges, you'll be thinking, yeah, we've done that, or you'll think this is something different that we haven't yet and something maybe to be able to consider. So that's where we are. I shall just get the clicker. That's our organisation where we've got the outbreaks in terms of that experience. And as you can see from there, it's a really, really old environment. It was built late 70s, early 80s. So before I even go into anything else, what you'll absolutely be able to know by sitting there is that's going to be challenging. And my goodness me, it so is going to be challenging. So what's the size of the problem? I've obviously anonymised this, so I'm not going to say which organisation it is or it isn't, and in terms of the data here as well, I've anonymised it for others within my area. So I'm obviously from the northeast, so you can see on the ones on the left-hand side in the red boxes, that's the organisation that I've had the experience with the CPE outbreaks in. The other three are different organisations within our northeast region. Now that will give you an idea of just the extent of the problem that we've experienced as an infection control team, but as a whole wide organisation. And I'll say as a whole wide organisation, and the reason being for that is that you know, we've all seen in the press just this week, they've talked about the A&E times, that absolute push from a patient flow perspective to be able to make sure we meet the ambulance times, the 12-hour waits, 12 weeks, that would have been a difference, wouldn't it? Would be all right for that. But, you know, for the 12 hours, getting that whole throughput through is a massive pressure. And for me, I've been an infection control nurse for 19 years. My experience now in dealing with any outbreak is very, very different to early on in my career as an IPCN because of the bigger pressures, the bigger difficulties that we've got. You've got the challenges to be able to make sure we try and maintain flow. We've got the financial challenges, so that some of the things that you would like to be able to do, we maybe can't do for many different reasons. So it's very, very different. You can see there by the sort of orangey colour, the extent of our problem really is by detecting these cases on screening, and we've got a really rigorous screening process to be able to pick up. There's some arguments, and we've had some, I wouldn't say arguments, but we've had some discussions within the organisation with regards to, well, we can't decolonise. It's not like MRSA, so why do we need to keep looking for this, Angela? What do we need to be able to do that for? Can we not just say, right, we'll stop screening and then we won't know the problem? Well, actually, no, that's a little bit more worrying. So we keep in screening, and we have some practices that we absolutely maintain. What does that look like? It looks like that. So the previous slide gives you a real idea in terms of, yes, we're picking up most of these screens by doing screening. So we predominantly obviously do rectal screens as part of that. We don't have a one enzyme outbreak. I wish we did, but we absolutely don't. One of our microbiologists calls it a soup, and they say that we have an absolute soup of organisms in terms of our outbreak, and you can see there on the other outbreak, the other slide shows you sort of in a much more prolonged time frame. But this really shows you that breakdown month by month about what the cases are and what the enzyme mix is. That's truly challenging to be able to manage, really. What I would say is there was I don't know if people were here yesterday, but in one of the talks yesterday, we were talking about antimicrobials and cleaning and things like that. And what they were saying is actually when we went right the way back and cast your minds back to when we didn't really have much experience with CPE and you got your first CPE case and everybody was really worried. They were in a cubicle, they adhered to all the PPE and everything like that. Once it's become more commonplace, and it really resonated with me because he spoke about actually it's more worrying now because people don't see that in the same way. And I feel that because of the amount of CPE that we have currently, you know, there's this idea that, you know, it's okay, it's rectal carriage. We're not seeing a high conversion rate from colonisation into infection. That's a true positive, absolutely it is. But will it always be like this? Probably not. You know, we're going to get patients who are going to, you know, get more infections and we're closely monitoring that. So that's a true challenge for us. David, I have envy because I've just come from your presentation with estates and your beautiful space with your 4 beds. I feel like, you know, one of these game shows where, you know, you could have won this, but this is what you've got. And I've got the booby prize, I have to say. So the spacing that we have in the environment is within the red space. And in that red space, we have 6 beds. So you can imagine just how close that is. It's really, really tight and it's really, really challenging. It's challenging to be able to do everyday care, really, in terms of that for space. But from an IPC point of view, it's even more challenging to be able to have it. So we definitely have the baby prize. Nope. Let's stick it this. There we go. Oh, sorry, it's gone ahead. Yep, sorry. Right. So I thought pictures say 1,000 words, say much more and have much more of an impact than me standing here talking, to be fair. So in terms of this, you know, you've got an idea there about the age of the building, what the floor space is, and then throw into that, what does that look like? So the first picture starting on the left-hand side there, that was the environment on one of our wards with a CPE outbreak. Now then, you can see how close the proximity is to be able to enter into that bay from what that patient's curtain is to be able to get round. Hiding behind that is the second picture where you've got your clinical hand wash basin. So really easy to access? Not. And you can see the close proximity between the clinical hand wash basin and the curtain. And this morning when we were talking about water safety, is quite good and really it all ties in terms of the risks with CPE, you can absolutely see what them risks are because we all know that there's lots of evidence for splash zones being 2 metres. And you can see there that proximity to that patient will absolutely be within the 2 metre splash zone. I thought I'd show you and demonstrate the environment and the challenges before I then show you our sort of list of long interventions that we've done during the time for our outbreaks. As part of that, what we've managed to be able to do is get a full refurbishment of one of the wards. Now, I will only say that it is one of the wards. It's been super expensive, really, really difficult. We don't have a decant ward, so that was quite hard to be able to move the ward to a whole different site. Getting the medical cover and all of the nursing cover and everything else that goes along with that was a real challenge. But what we have got is a much better environment. So you can see there on the third picture, that's where the patient zone is. So instead of the clinical hand wash basin being sort of such close proximity and really hard to access, we've now taken it outside of the bay, so we can't access it from the bay. We've moved it out, so you now access all the clinical hand wash basins from the corridor, which is the last picture there, and it's sort of in an inset to be able to access, flagged down to be able to show with some signage that these are the hand hygiene stations. So we've taken away from there. that was really difficult to be able to achieve, I have to say, to win hearts and minds, and everyone thought I was a little bit strange and a little bit crazy, and did I really want to do that? And I said, yeah, absolutely, and really worked with the ward team for how we could work differently. The flow from clean to dirty, obviously that's been mentioned today as well. Absolutely look at the restrictions that we have in terms of space and what that risks are. So you can see at the top where your splash zone would be from the sluice master to your beautifully clean commodes with your I am clean label. Are you really clean? No. So, really having a look at that. We had, reviewed on the ward that we did the refurbishment with was what was our usage for the water outlets in terms of risk for CPE. We know that we've done an awful lot of work to be able to identify CPE from some of our wastewater outlets that has correlated with sequencing from patients. So we looked, as well as moving the access for the basins, but actually getting rid of some outlets that were just too much of a high risk or weren't needed because they were underused. The bottom two pictures as part of that refurbed area, this ward particularly is quite lucky, I suppose, because the sluice area is really rather large. So we've taken out the decontamination sink, which is in the left-hand corner there, and on the right side, them cupboards are all smooth cupboard space. It's touch points, you haven't got any handles to be able to just open, and the storage space has been massive for them. And it's really had a great morale point from the ward staff to be able to have, because they really enjoy their environment. Here's something to consider wider. So what's the wider risks in relation to that? And we focused a lot in the clinical area, and then we started to look at actually what are our other risks, what else is going on that we haven't seen. I would have never thought in a million years, and neither did anybody else, that they were putting in the zonal kitchens the porridge down the sinks, rather than in these containers to be able to have. But actually, when you spoke to the staff, they had a rationale for it, because when you put all of them in, it was really heavy for them to be able to lift, and they really just needed that education to understand actually what the risks were to be able to dispose of things down the wash basins. We've had positive environmental samples. I know Gamma's here today, and they've been really helpful in terms of supporting us with some environmental sampling. We've done screening that's been done in our own labs as well, and we actually identified CPE positive swabs from our environmental screens in the zonal kitchen on patient trays and also on the draining board, and really looking in that area about what was the flow between the clean and the dirty, and also getting a task and finish group to be able to look at the beverage bays and what's underneath the beverage bays where the water traps are. So there's been an immense amount of work, and at the end there, that just shows you the splash screen that they put up to try and make sure that there was no splash from the hand wash basin to the drainage board, so that we could try and prevent that contamination. The green arrow is the green arrow that I really like, because that's where we ended up getting to no outbreaks. But I'll be really honest and say now we have got some again, and that's why I really don't enjoy a CPE outbreak. But we've done lots and lots of things. So you can see there the amount that we had. So we've done peracetic acid drain decontamination. We've moved to, and I won't call it waterless, but water light bathing. We started as a trial, and then we've moved that out to all outbreak areas now. So if they're in an outbreak area with CPE, while we're waiting for the areas to be refurbished, we use water light. So we really promote with patients to be able to not have a shower, because we've got some showers that haven't been refurbished yet from a drainage point of view, and to really promote water light. We also picked up CPE from our floor scrubbers with the environmental screening, and if you look at the National Cleanliness Standards, the floor scrubber is the last point to be able to use, but actually if they're getting contaminated with CPE as part of that clean, we've gone and deviated from that. So we put a paper in to be able to ask for a deviation from the National Cleaning Standards. We do the floor scrubber first, and then we'll do the touch points just in case there's that spray off. Janine, I shall go over to you. Oh, I suppose one other big thing, sorry if you don't mind, is we stopped the use of the clinical hand wash basin. So though we can't remove it where they're in a splash zone, we've stopped the use. And on the far right there is a cover that we've got to be able to put over them so that we can still run the water to flush, but they won't have that splash zone there. I think they were really key in terms of some of the real impacts to be able to try and reduce the outbreaks. But I'm conscious of time, so I shall stop. Thank you.
So I'm Janine Patrickson-Daly, Regional Head of Infection Control for NHS England, North East and Yorkshire. So I work with Angela and all the other IPC leads within the region. So I'm just got a couple of slides just to talk to you about what my role and responsibility is in terms of supporting trust when they're experiencing an outbreak such as this one. So my main role is quality. So we have got a quality function, and that's to oversee ICBs for IPC and for AMR and AMS. So I work very closely with my regional AMR lead. We work jointly in partnership, looking at both IPC and AMR, and looking at the NAP, the new NAP, and how we're going to implement that within the region. Main part of my role, I would say, do on a daily basis, is monitoring the NHS standard contract for the HCI thresholds. So we have oversight and scrutiny of these and any other IPC contractual requirements and improvement programmes. We work very closely with UKSHA colleagues in sort of oversight and response to other emerging threats. So the last few months, there's been a lot of work around monkeypox, I'm sure you're all aware. We have a regional IPC and AMR board where we share learning, we identify risks and escalate concerns, make decisions on what risks and challenges we need to escalate within the region and also up to the NHS national team. We assist systems to translate and implement national policy, such as the National IPC Manual for local implementation and delivery. We provide IPC leadership to the ICBs to give them the direction in terms of IPC and AMR. We have oversight of regional capacity in terms of workforce. So this is to identify any gaps and risk and how we can support that from a regional perspective. And then we work with workforce colleagues within the region to support educational programmes, and that's both in terms of delivery and commissioning of education. So in terms of support, as I've already mentioned, that we have that oversight and regulatory responsibility for IPC performance. So every month we have a tripartite meeting with UKSHA colleagues, so that's with our public health consultant, the AMR lead and the ICB SRO for IPC. So when we have this meeting, we look at HCI data, we look at prescribing data, and again, try to, wherever possible, share good learning that we can share across the region. But it's mainly to identify outliers and agree the next step. So it's about region working with the ICBs and then working across the system where we've identified outliers in terms of what we need to do to support them. So in terms of supporting Angela for this CPE outbreak, I was initially alerted about the outbreak from our UKSHA colleagues, the public health consultant. So the next step for me was to put a call in with Angela as Trust IPC lead to discuss the situation, current situation, what the challenges are, what actions have been put in place so far, and identify any additional support. I attended the IMT, so we do try to attend IMTs when an outbreak first happens, just to get a real good sort of feel for what's actually happening. I have regular communication with the ICB SRO for IPC to keep him abreast of any developments or any concerns. Part of my role is to signpost to peers and specialist advisors. So in this case, Dr. Jessica Martin at our Leeds Trust has done an awful lot of work on water safety. So we put Jessica in touch with Angela, and Jessica actually came up to do a site visit and give lots of advice on the work that they'd been doing. We also put the Trust in touch with Mike Weinbrunn as a specialist advisor on water safety. And again, Mike did a visit, Our public health consultant from UKSHA also attended this visit, and between them a report was written giving recommendations, and part of that recommendation absolutely supported in the financing of the refurb of Ward 52, isn't it? So really useful to get that expert knowledge up there to help support and say for improvements to be made. The Trust developed an improvement plan, and that's been monitored continuously with myself and the ICB, and we continue to do that, working with Angela and others responsible within the Trust. And I like to see my role as a critical friend and a bit of a sounding board, so we're always there at the end of the phone. But yeah, absolutely, you know, we're not there to criticise, point the finger, we're there as a critical friend and to be able to be that sounding board to say, and direct people in terms of signposting. And then just my last slide is just to let you know about the difference in role and responsibilities between UKSHA and myself within region. So UKSHA don't have any role in terms of performance and assurance, so that's down to NHSE. So UKSHA's role predominantly is to provide advice and support on epidemiology, microbiology, IPC, AMR, AMS. And our local team up in North Eastern Yorkshire includes a great team of field epidemiologists that are really useful to know. They can produce risk factor data reports for us. So within our region, we're an outlier for Klebsiella, so we held an event back in March, and so the preemptive work before that event was looking at those risk factors, and that was something that the field epi team could do for us. They've got health protection teams, consultants in public health, and they're absolutely a great source of information, support and advice.